This lecture is about lower respiratory tract infections. We're going to cover the three most important clinical syndromes that fall under the umbrella term of lower respiratory tract infections. Those are acute bronchitis, acute exacerbations of chronic obstructive pulmonary disease, and community-acquired pneumonia. Beginning with acute bronchitis. The definition is a self-limited inflammatory process involving the large and mid-sized airways. Typically, the patient will have acute cough lasting up to 3 weeks, often producing green sputum. It's critical to note that the production of green sputum is not in itself an indication that the patient has a bacterial infection and requires antibiotics. These patients have normal vital signs, they have no signs of pneumonia on their chest examination, and they have no associated infiltrates on chest X-ray. The pathogens are predominantly viral. These include influenza, parainfluenza, respiratory syncytial virus, and human metapneumovirus, and there are a small number of non-viral pathogens. These should be suspected if the condition is prolonged, has a longer incubation period, or if there are local outbreaks. And organisms that can cause this include Mycoplasma, chlamydia species, and Bordetella pertussis. It's important to note that bronchitis has no association with common respiratory pathogens such as strep pneumoniae and Haemophilus influenzae unless the patient has evidence of underlying lung disease. In terms of investigations, the vast majority of cases require no investigations. There is no need to perform a Grand stain on the sputum, and a nasopharyngeal swab for influenza PCR is not recommended if the patient has simple, uncomplicated influenza-like illness. In terms of management, antibiotics are not indicated. Overprescription of antibiotics for bronchitis is one of the commonest mistakes in antibiotic prescribing and is thought to be a major driver of worldwide antibiotic resistance. It's important to explain to the patient that the illness will last for around 3 weeks and advise on symptomatic treatment with drugs such as paracetamol and non-steroidal anti-inflammatory drugs. Acute exacerbation of COPD is defined as an acute increase in baseline dyspnea or shortness of breath with cough and/or sputum above the normal day-to-day variation. This must lead to the patient needing to change medication, and they must have a pre-existing diagnosis of COPD. Up to 80% of exacerbations have an infectious cause, and this is most commonly viral. The common pathogens are typically viral, and this is more common in the winter months. They're viruses such as rhinoviruses, parainfluenza, coronavirus, influenza, and respiratory syncytial virus. There are also some bacterial causes. Usually they're typical respiratory pathogens such as Haemophilus, Streptococcus pneumoniae, Moraxella catarrhalis, and they can be Enterobacteriaceae, particularly in patients who've had frequent hospitalization and antibiotic use. It's important to note that in acute exacerbation of COPD, atypical bacteria such as Mycoplasma and chlamydia are not implicated, and patients rarely require macrolide antibiotics for this reason. In terms of test, sputum culture should be reserved for patients with severe exacerbations or moderate exacerbations requiring hospitalization when there have been frequent admissions or there is a poor response to antibiotics. In mild exacerbations, sputum culture is not required. CRP has been used to try and determine which patients with acute exacerbations of COPD require antibiotics, and different cutoff values for CRP have been used. In general, if the CRP is less than 40, then antibiotics are not going to be required. And if the CRP is greater than 40, then antibiotics may be beneficial. But it's important that you don't use CRP in isolation and take into account the severity of the COPD itself and the clinical condition of the patient. In terms of antibiotics, although many exacerbations are viral, it can be difficult to determine which are bacterial. And antibiotics may be indicated, particularly if there's increased sputum purulence, which, although not perfect, is one of the better clinical predictors of bacterial infection. Also, if there's increased dyspnea or sputum volume, and certainly in patients who require mechanical ventilation. Patients with mild exacerbations will be seen as outpatients, and generally amoxicillin orally is reasonable, unless they have significant comorbidities, greater than 3 exacerbations a year, or have had antibiotics in the last 3 months, in which case co-amoxiclav may be a better choice. Patients with moderate exacerbations requiring admission to the general ward do not necessarily require antibiotics, but if they fulfill these criteria, then oral and in extreme cases intravenous co-amoxiclav is a reasonable choice. Patients with severe exacerbations requiring admission to high care or intensive care should be given antibiotics, and either intravenous ceftriaxone or co-amoxiclav are reasonable choices. Prevention of acute exacerbations of COPD is extremely important. All patients should have an annual influenza vaccine. They should also all have pneumococcal polysaccharide 23-valent vaccine. Antiviral prophylaxis, however, is not recommended. Turning now to community-acquired pneumonia, which is an acute infection of lung parenchyma distal to the terminal bronchiole. There are a number of clinical definitions of pneumonia. The following one is in common use. It's an acute respiratory tract illness associated with radiographic shadowing on an admission chest radiograph consistent with infection, which was neither pre-existing nor has any other known causes. Common pathogens are Streptococcus pneumoniae, which is the most common, followed by Haemophilus influenzae, which often occurs in patients who have underlying chronic obstructive pulmonary disease. So-called atypical pneumonia is caused by organisms that cannot be cultured and show no response to beta-lactam antibiotics, that is, penicillins and cephalosporins. A common misunderstanding is that atypical pneumonia presents with atypical features, whereas in fact it's not possible to determine the etiology of community-acquired pneumonia from clinical features alone. Tuberculosis causes pneumonia, and that's common in HIV-infected patients. And pneumocystis pneumonia, which presents with bilateral infiltrates in HIV-positive patients and also shows no response to beta-lactams, is also common. So how to diagnose CAP? Well, first you need clinical evidence in the form of a fever and/or breathlessness and tachypnea and/or tachycardia. Plus, you need clinical evidence of consolidation. In an outpatient setting, that means examination findings, or in an inpatient setting, that means new or progressive infiltrates on the admission chest X-ray. Once the diagnosis has been made, it's important to score the severity. There are a number of severity scores, and one of the easiest to use is the CRB-65 score, which is a slight variant on the CURB-65 score, but does not have urea and therefore does not require any blood tests. Patients score 1 point for each of confusion, respiratory rate greater than 30, blood pressure less than 90 systolic or 60 diastolic, and age greater than 65. This table shows how CRB-65 score correlates with mortality and gives suggestions of whether patients should be treated as outpatients or inpatients. So when the score is 0, the mortality is very low, and you can treat people as outpatients. When it's 3 or 4, mortality rises to above 30%, and patients should definitely be treated in the hospital. When considering what treatments to use, it's important to take into account the severity scoring, as well as the clinical condition of the patient. If they have mild disease, then oral amoxicillin is usually appropriate. If they have moderate disease, then co-amoxiclav orally is appropriate. And in severe CAP, you should use an intravenous antibiotic, either ceftriaxone or co-amoxiclav, along with a macrolide, either azithromycin or clarithromycin, to treat atypical organisms. Sometimes patients fail to respond to the first 48 hours of antibiotics. And these are some of the considerations if that happens. Firstly, if the patient's not been on a macrolide, that is azithromycin or clarithromycin, you may want to add one. It may be necessary to investigate for tuberculosis. If a patient has HIV and bilateral infiltrates, then empiric PCP treatment with cotrimoxazole may be necessary. And you should repeat the chest X-ray to exclude effusions which might be infected or abscess formation. So in summary, acute bronchitis does not require antibiotic therapy. Aminopenicillins alone are advised for all grades of severity of acute exacerbations of COPD. Annual influenza vaccine and pneumococcal vaccine are recommended for all patients with COPD. The CRB-65 score determines the severity of CAP and guides decisions regarding admission and IV versus oral antibiotics.